Welcome to the Center Collaborative, Creative Solutions in Behavioral Health and Criminal Justice, brought to you by the Oregon Center on Behavioral Health and Justice Integration, which is also known as the Center. We at the Center are all about solutions. Our job in Oregon is to facilitate improvement of the system so behavioral health and criminal justice can work better together to engage people in treatment while promoting public safety. I am your host, Chris Thomas. I hold a master's degree in clinical psychology and have focused on the intersection between behavioral health and criminal justice for 20 years. Over 7 of those years were behind the walls of a maximum security prison. During this podcast, you will have the opportunity to sit in on real, in-depth conversations with experts about complex topics in a way that is both fascinating and digestible. We will focus not just on what is wrong with the system, but what is going right and how we can work together to evolve. This podcast is a conversation in a series of conversations where we touch on people's legal rights and their options related to seeking medical care. Since our conversations are intended for informational and educational purposes only, they are not a substitute for or a reason to delay seeking professional legal or medical advice. On today's episode, I am joined by Dr. Ericia Leeper and Dr. Andrea Avila. Both are psychologists and certified forensic evaluators in Oregon. They join me to talk about Psychiatric Advanced Directives, or as they're known in Oregon, Declarations of Mental Health Treatment, DMHTs, which are used to inform treatment when a person is within a crisis and the person does not possess the ability to consent to treatment. DMHTs allow the consumer to communicate in writing what treatment works for them or doesn't work for them. This supports the continuity of care with the consumer's voice. Consumers can appoint a trusted representative to carry out decisions outlined in the DMHT while that person is in crisis, but it reverts to the arrangements before the crisis after the ability to consent returns. The content and dissemination of a DMHT is up to the consumer. Because of this, DMHTs are an important potential tool for supporting diversion from the criminal justice system. Anyone can talk about DMHTs with a consumer, but there are restrictions around who can be witnesses or representatives. We talk about the research around DMHTs and how to find the paperwork on the web. Dr. Leeper and Dr. Avila are joining the podcast as psychologists and certified forensic evaluators, not as representatives of OHA or OSH. Dr. Leeper and Dr. Avila stated they would rather be addressed by their first names throughout the podcast, so you'll hear me call them Ericia and Andrea. We are thrilled to have the opportunity to talk about this important but not well-known tool. Welcome to our conversation. Welcome to the podcast. We're thrilled to have you here with us today.
Thank you so much. We're very happy to be here.
Yes, we are delighted. Thank you for having us.
So let's start off first, I think, for our listeners, talking about what are psychiatric advanced directives?
Psychiatric Advanced Directives, or in Oregon, they're known as Declarations of Mental Health Treatment. And essentially what that is an avenue in which a person can direct their healthcare treatment when in crisis. So it's a way for an individual to establish what they would like to have happen with them should they be in crisis and not able to make those decisions on their own.
It's basically a way of giving informed consent in advance. It's very analogous to a living will or a healthcare advance directive, where people identify what they want to have happen in the event that they're incapacitated by a coma or something like that. It's the same type of idea. It's just in the event of a psychiatric crisis.
So it allows somebody, when they're stable, to be able to make decisions about their health care and be able to have that in writing for if they do go into crisis, then those wishes are known instead of not having those wishes known when someone goes into crisis. Am I wrapping my brain around that?
That's correct.
How are they helpful?
How they can be helpful is something that I think is really important and something that I think that people are missing because of not having the information available to them. So in a perfect world, what would happen is that somebody would be educated about these, somebody would fill out this form. So there's a form that the OHA has that includes all of the pieces that it needs to have per statute. And once someone has this completed and it's put on file with their provider, a local emergency room, potentially law enforcement if they saw fit, and then if somebody was in crisis and came to the attention of someone, their representative could be contacted, and really they could just be redirected from any or diverted from any maybe more negative system. And so rather than being arrested, maybe they're taken to a local ER at the request of their representative to the ER of their choice. Say they're arrested or came into contact with law enforcement in their town. They could go to a local ER, two physicians would see them, make an assessment about whether or not they were incapacitated. And if they were incapacitated, then they would rely on this declaration of mental health treatment that they previously filled out. So say this person has a history of mental illness and a history of being treated with medication A, and medication A has been super helpful with them and ameliorating their symptoms, they could start there instead of a different medication that this physician typically prescribes first for any patient that they see with this kind of combination of symptoms. And so it can cut to the chase in that way. It can prevent someone from being arrested. It can prevent someone from trying to meet this high bar of civil commitment. And so the representative, with the individual's permission, has the authority to have someone hospitalized for up to 17 days without having to meet this really stringent standard of civil commitment. So they don't have to be in immediate danger to themselves or others. They just have to have two physicians indicate that they're incapacitated from their mental health symptoms, and then they would start referring to the form about next steps. I know that was a long way around answering that question and how they could be helpful. Andrea, do you want to add anything to that?
I think that was a good description of how, for an individual, this could come up, of a sort of rubber meets the road. So to complement that, I'll offer like a more zoomed out view of some of the research that we have about how these have been helpful for people. So prior research has indicated that people find these helpful because they can increase a sense of autonomy and self-direction in their mental health treatment. Prior research has also indicated that consumers find it very meaningful to be involved as like a responsible agent in the direction of their healthcare treatment in the future. And in particular, one study found that consumers found it very meaningful that providers believed them and trusted them as they tried to take agency in their healthcare choices, that they had this document that showed what they wanted in the event of a crisis. Research indicates that overwhelmingly, like over 90% of the content in DMHTs is clinically useful for providers and is enforceable and is helpful information. And there's also been shown to be a reduction in negative outcomes, things like coercive treatments. People are more likely to comply with treatments that they've assigned to themselves. So of course they're more likely to comply with it in the future. It's something they chose. But I think that those are the ways that it can be helpful, both as applied and then in a more general sense.
It makes me think of giving someone agency and voice in their treatment. It also makes me think of guardianship and some of the conversations that we've had about guardianship, and that is a very expensive and also a very long process and can be in play for a very long time. This seems through these directives, you can have someone that you trust making those decisions in the short term, but that there is an end date for that.
Exactly. So if somebody is thought to regain their capacity, and again, this is under the assessment of a physician, once someone is restabilized, then they would go on about their lives as normal. So if they were living independently, they continue to live independently. If they are employed and have a job and drive, like all of those things can resume. There is not this overarching indefinite period of control. It's I'm unwell. I said when I'm unwell that I would like these things to happen, or I give you the permission to help me with achieving these things, seeing my prescriber, being assessed at a facility if I need that kind of assistance. And once I'm stable, things go back right to where they were prior to the decompensation. And so I do think it's really important to point out the ownership that somebody has in their treatment. Say you live in Portland and there are many hospitals in Portland, and for whatever reason, you have a bad experience with Hospital 1 on your declaration of mental health treatment. You could say that if possible, that you would like to go to hospital number 2. That's where you have a trusted relationship with people. And so those types of things within reason can happen. If it's for whatever a dire situation and you're closest to hospital 1, some of those things can be overridden so long as they're happening in good faith. So when we say happening in good faith, it also does not restrict the clinical opinion of a provider. So say someone asked for medication A and on their medical assessment, there's some contraindication to that medication. Say there's some kind of medical diagnoses happening and that physician knows that they shouldn't prescribe that medication. They can prescribe the next best thing. And those things, so long as they're happening in good faith, can allow for the physician to still have their clinical abilities. It doesn't restrict them in that way. That may sound scary that you're going to write this plan out and now people don't have to follow it, but it's really them not following it only when it's in your best interest that they don't follow it. So if it would do more harm than good for whatever reason, then they can override that. And not in a scary, causing harm way, but in your best interest way.
I'd like to add 2 things, if I may, one in response to Erica and one in response to something you said, Chris. But to supplement Erica's point, I think it's important to remember that these documents are essentially informed consent given in advance. So in the same way that if a patient walked in and with full capacity to consent to healthcare treatment said, I would like medication A, and the doctor looks at their chart and says, I'm sorry, there's a contraindication here. I can't prescribe that to you. Let's pick something else that's close. In the exact same way that happens, a psychiatric advance directive or declaration for mental health treatment basically just functions like that, but just written out in advance. So just like Erica said, if there's something in there that doesn't make sense or is against the provider's clinical judgment, it is not required to be enacted, just like she explained. And Chris, you brought up guardianship and how it can be a long, convoluted process. It's also not very easy to get started or to end. And most of the time, it can take over a large part of a person's decision-making capacity. And declarations for mental health treatment are intended to be more like elegant and agile response to what may not be a long-term functional deficit or global deficit. So declarations for mental health treatment are particularly a good fit for people with severe and persistent mental illness, as opposed to folks with an intellectual disability or something like that, because what we see in SMI is that it can be very episodic. There can be big differences between someone whenever they're functioning at their best or whenever they're having a psychiatric crisis. And the bigger that difference is, the more important it would be to have something that could turn on and off, as opposed to something that was more long-term or that had broader implications. So it's particularly a good fit for people with SMI or SPMI.
Flexible and nimble, I think, are really the words that are standing out for me around that piece of it. I'm also wondering if it gives, and I want to get into the nuts and bolts of what it looks like and what the options are here in a minute, but I'm also wondering, for example, when we were talking about the medication, or if someone had a bad experience at hospital A and they wanted to go to hospital B instead, is there also a place on the form to say, this is why this medication works for me, or this is why medications haven't worked for me in the past, or this is why I like this hospital versus the other? Are folks able to have the why in there instead of just the what?
Honestly, you can fill it out however you want. There's certainly prompts and information about your preferred treatment, your preferred outpatient provider, or who your actual outpatient provider is. There's predetermined space for the answers, but I would argue whatever you can fit in there is what you should put in there. So if you really had some kind of really negative experience, with any aspect of this. So you had a really poor experience to a medication and experienced really severe side effects. You can put on the form, please don't prescribe me X. I experienced significant tardive dyskinesia, which is a side effect of medication that causes involuntary movements that are really uncomfortable. The more information that you can provide on the form for people who are going to be users of the form, so hospitals, outpatient providers, prescribers, the better position you're putting your prescriber or that person in to help you.
If you've identified a representative or attorney in fact in your DMHT, that person could also hopefully provide some context as to why you made the selections that you did, and also collaboratively work with providers about if one of your selections isn't feasible for some reason, to identify something else that's going to reflect your wishes as best they can given the reality of the situation.
So to piggyback off of what Andrea said, so on the form, it allows you to identify the name of your representative or attorney in fact. Those are synonyms. In the statute, it talks about an attorney in fact and a representative being one and the same. And then also on the form, it uses the simpler language of representative. So you can identify your representative, their name, address, phone number, and then an alternative if that person is unavailable for whatever reason. And then on the form, it says, I consent to the following mental health treatments. And in parentheses, it says, may include types or dosage of medications, short-term inpatient treatment, a preferred provider or facility, transport to a provider or facility, convulsive treatment, or alternative outpatient treatments. And then there is roughly 3 blank pages of just lines where that person can fill in what they want and how they want. So you could do a bullet point of your preferred hospital, your preferred prescriber, your preferred outpatient clinic, and why you have those preferences. And so there's nothing on this form to prohibit you from explaining why you want something. And then alternatively, why you wouldn't want something. And then the form also has some guided instructions for things to think about for several pages prior to those aspects of the form. This form was created by OHA to use in conjunction with making sure statutorily it includes everything on there. There's about 4 pages of instructions with really simple questions. It has a very easy, digestible way of explaining A, what a DMHT is, and B, how you can utilize it for when you're in crisis, kind of the constraints for what it can and can't do.
When is the best time to have this form filled out?
I think any time in advance of a psychiatric crisis, even if it's not your first psychiatric crisis, is a good time to consider filling out this form. Obviously, this form is intended to help people plan for the future and hopefully divert people from more problematic outcomes or more negative outcomes. Really, any time in advance would be ideal. In terms of things that they want to know before they sit down to fill out the form, hopefully they've had a chance to think through what they would like to happen in the event that they're incapacitated. It may be easier to imagine that if it's something that they've experienced before, and they may already know what they want, especially if they have a provider, if they have treatment that's working for them. It may be a little bit more difficult for someone who doesn't know all of that yet or hasn't experienced those things yet. But they would also want to think about whether or not they wanted a decision maker, someone to step in and be their representative. And so even if someone has never had mental health treatment in the past, maybe they just have a family member who has a mental illness and they want to prepare in the event that they are similarly impacted. They could just think about who they would want to make decisions for them. If they trust that person and discuss with that person what they would like to happen, then they can even just identify the representative in their declaration for mental health treatment. And that may be enough to make them feel safe about how things would go forward. The other thing that you asked about was nuts and bolts. In addition to a representative, you need 2 witnesses for whenever you sign the document. And this process is very analogous to executing a will. You need two witnesses, and it's the same sort of statutory language about the witnesses need to know who you are, and they're basically just saying that you're of sound mind. And so I think because we're talking about psychiatric incapacitation, sometimes people get concerned about who the witnesses could be. Do they need to be someone who's formally assessed the individual's soundness of mind, whatever that may mean in the moment? But according to the language, it's very analogous to having a will executed. You just need two people to document that you're there, you're not doing it under duress, you're doing it of your own free will, you appear to be of sound mind. They don't even need to know what's in the DMHT. They're just witnessing you sign it and saying that no one was forcing you to do so. There are some limitations about who can be a witness and who can be a representative. Erica, you know those pretty well. You want to do those?
Sure. So people who can't, or really anybody who's going to monetarily gain or be in some sort of position of advantage over you if they were your representative. So your representative cannot be your prescriber. Your representative can't be an employee or can't be the superintendent or the COO of any facility that you're at. So think about neutral parties in someone's life, whether this is a friend. It has to be someone who's not going to stand a profit from your crisis. And really, that's the guiding principles about what's involved in the statute.
In some of the conversations I've had about this form and this process, some of the confusion that folks have, because statutory language is not exactly the easiest language to read and understand. So I think some of the confusion I've heard is that folks see this piece about who can be your representative and who can be your witness, and then assume that because there's those exclusions, I can't even talk to you about that. And in the conversations I've had with y'all before, my understanding was anybody can bring this subject up. It's just you can't be the representative or the person who signs as a witness. Is that right?
As far as educating somebody about the process, is that what you mean?
Yes, saying, hey, you're doing well right now. If you want to think about in the future, if something happens, this is something you might want to consider. These are some things you might want to think about for the form, not necessarily telling people what to put on the form, but things to consider, that anyone can have that conversation. They just can't sign it or be a representative.
That's right. So if I'm someone's outpatient provider, and this is actually a guideline by the statute, that outpatient providers and medical facilities should be educating their patients, the individuals they serve, about the existence of declarations of mental health treatment. We know from our research that not a lot of providers know about it. That's likely not happening on a very grand scale. The first part of the question, any provider, prescriber, facility can provide this education. So when I think about someone who, say, maybe is in an inpatient situation and is improving with medications or is becoming more stable and they're preparing for discharge, that is a beautiful time to have a conversation with someone about what do they want to have happen should something like this happen again. And to explain, assuming that they want to avoid something like this happening again, that there's a way that they can be the driver of their own treatment in the future. So that's a beautiful opportunity to explain that psychiatric advance directives exist, the declarations of mental health treatment exist, and then on that form, they're free to delineate the things that they've learned from their lived experience. So that's your opportunity to say, I prefer this medication because it worked better for me or quicker for me with less side effects for me than this other medication that I also tried. Or I prefer this prescriber because we really have a good relationship and really see eye to eye about my diagnoses and the things that I need. And it's just a fantastic opportunity to allow the person to explain to someone who doesn't know them what they've already learned about themselves and about their serious mental illness. And so it's almost like a shortcut to, hey, like, you don't know me, but I'm going to give you the opportunity to get to know me really, really quickly, because this is my well self telling my ill self that it's okay, that these are the things that you've given permission before, because these are the things that have worked for you. And I have to think that on some level, having a representative, if somebody's in crisis, remind the individual that these are the things that specific individual had asked for the next time they were in crisis. And so that representative is simply there to help them get those things that they wanted. I would have to think that's got to be disarming to the person. And on some level, granted, if we're in a very significant crisis, maybe we're not able to have these kinds of cogent thoughts. But I have to think that even if somebody's in crisis, that has to put them at ease and say, okay, this person's on my side. And they're reminding me that these are the things that I had asked for, and they're just going to help me meet those things.
Well, especially as a representative for someone that you love and you're helping make decisions around, because when your loved one is in a moment of crises, you are also emotionally in a moment of crises as you're trying to make a decision because you love your loved one and you want
Right.
to make sure that you're making decisions that represent what they want. And so I can imagine having it written down in your loved one's own words has to be so comforting because at least you know this is where your loved one was coming from when they were doing well. And I can imagine that's a lot less agonizing for the representative helping make decisions for that person because they know what they wanted versus like with other advanced directives and something happens and there's nothing there and someone's in the hospital and ICU and they say, what are we going to do? And you don't have anything written down, how agonizing that is. So it
Right.
gives an opportunity to have some comfort for that person as well who is making decisions.
Absolutely. And I'd have to think that it feels in a much better position to know that you're just executing information that they already want versus trying to figure it out as you go along. What if this isn't the decision they want me to make? There's no guesswork in that way because a lot of the path is already determined, a lot of the path is already figured out. And so, what I imagine for implementation is if I have a family history of mental illness, I may want to get one in place, even if I haven't experienced a level of crises, just in case something happens. We know that as people become more symptomatic, sometimes their insight decreases with that. And so I may not be in a place as I'm developing symptoms to recognize something's amiss. I should probably go check in with my therapist, or I should probably go check in with my psychiatrist to make sure that my medications are still working properly. That's really hard to have those thoughts and to be that on top of your symptoms, especially if you're early in your illness or pre any kind of crisis. And so if I have this already developed and something's amiss and my loved ones recognize this, they can enact it. They can help me help myself. What a wonderful situation to be able to provide the autonomy to a person, even when they don't have that autonomy in that moment, that it's coming from a place where it's what they want, it's what they say they need. And it's often based, similar to what Andrea was saying earlier, to have a provider trust them. It's based on information that they have about themselves that provider doesn't have. And so I think instead of guardianship or conservatorships that often feel punitive in this way, where there's this dynamic of control and power over an individual, this is giving that control and power back to the well person, allowing them to say, here, this is what I know I need and want when I become unwell. And they get to say that when they're well. And so when they would become unwell, there's no guesswork and, oh gosh, what do we do?
Well, and I would imagine too, also with things like medications and medication side effects, when you're not feeling well, I'm allergic to all kinds of medication. I've got a list. And if I go into the doctor and I'm not feeling well, let's say I have to go into urgent care, I've broken my arm, I've done whatever, I have a fever, and I feel horrible. And the doctor says, what are all the things that you're allergic to? I'm like, don't you have a list? Because
Right?
I can't remember them all, right? And what do they do to me? I don't know. Don't you have a list? Because at that moment, I feel horrible and I can't really talk about it because my brain is elsewhere because I feel terrible. And so I think also this could be helpful in those moments of when I'm feeling well, I can sit down and think about what medications or other aspects of my healthcare and my psychiatric healthcare I can sit down and think about those and write them down when I'm feeling well. So when I'm in crisis, I don't have to remember all those things. It's like having a cheat sheet for you in the middle of crisis when you're not doing well.
Absolutely. I think a cheat sheet's a really nice way of looking at it and a really simple way that people can grab onto. It's just a map. It's a roadmap to treatment. And it's easier to get to point A to point B when you have a map, if you've never been there before, than it is to figure it out on your own. And so you're providing a guide to someone who may not know you or know you as well, compared to someone who is sitting in front of a prescriber for the first time. And I say this from a perspective where it seems like that somebody would always be in front of someone who doesn't know them. That doesn't always have to be the case. If you're unwell and you're refusing to go to your psychiatrist, but when you were well, you said, yes, help me see my psychiatrist, this can just help you get in front of your provider. We've all heard that stereotypic story where someone's on medication and stable and doing really well, and then they start thinking, well, I'm doing pretty well. Maybe I don't need this medicine anymore. And so maybe they stop taking it as consistently. Or even worse, that people really don't think about very often, is sometimes symptoms break through even if you're completely compliant with your medication. And so now I'm doing all the things I'm supposed to be doing, and for whatever reason, it's just not as effective as it used to be. And so now my symptoms are coming through. Having one of these in place can just help your representative or your loved ones get you back in front of your psychiatrist and say, I know they're taking their medications correctly. We talk about medications often. They have a medication planner. They have all these things in place and they're doing all of these things and it's not working. And so just having the ability for your representative to get you in front of the people that you already know, this can be helpful. One of the things I wanted to circle back to was talking about diversion. If you have one of these forms in place and you've filed it with your local emergency room, local law enforcement agencies, if you feel comfortable doing so, and local clinics, like popular clinics that are in town. If something happens where I come to the attention of, say, law enforcement, if something happens and I'm causing a ruckus in the community and someone calls the police, if we can make it to where people know where to look for people who have these in place and can look and see before we move further, does this person have a declaration of mental health treatment devised and in place? As soon as law enforcement gets the call, they could be running a person's name in a database and seeing that they have a declaration of mental health treatment and calling the representative before they even make contact with the individual. Now, granted, there's a lot of things that have to happen before we can get to that place. And so that's me with rose-colored glasses. Our systems beginning to be in place to allow for that sort of utilization. There is, according to the OHA website, the Voluntary Mental Health Database. And there's a consent form allowing the person to file their DMHT within this voluntary mental health database. I don't have any real world experience about how involved the database is, how easily accessible it is. But one of the things that Andrea and I are really interested in doing is public outreach. We've developed a toolkit about DMHTs with our current workplace. We would love to share this toolkit with other organizations in the community, add to the toolkit if there's holes in it, but sharing this toolkit with others and increasing the education about DMHT so other people can become aware of them. And that includes some outreach to our current law enforcement agencies, local police departments, local sheriff's office, because if we can figure out a central location where these can be filed and where dispatch can educate their officers that this exists, I can't imagine the level of diversion that could happen. DMHTs are not going to prevent a crisis from happening. But me with my rose-colored glasses on, if they're in place, perhaps we can keep the crisis from getting as bad. Perhaps we can get treatment in the early part of this crisis. And so we can divert someone and prevent someone from having these negative interactions with the community.
It is a work in progress, as Erica was talking about, but I think ultimately it's going to vary by individual and what that individual needs and what the people who they need to have know that this is in place. It's probably going to vary by community. Communities in rural Oregon are going to look different than Portland or Salem. It's going to vary by individual. And I think one of the important things to take away is that it is going to be on a voluntary basis. So just like everything else about DMHTs, this part is going to be self-determined by the consumer. So they get to pick who they want to have know about this. And to a certain extent, the more people who know and who have access to it, the more likely it is to be effectively implemented. But it's up to the individual about how they would like for this to be implemented for them. And earlier, Erica, you were talking about different services that people could access. And I had the thought that it's important to note that if someone does not have capacity to consent to treatment, if they tried to seek out any of those services on their own, they would not be able to validly and legally execute an informed consent to be involved in that treatment service. So what we're talking about is people who do not have the capacity to consent to treatment. And so by having this sort of crisis plan in place, this legal documentation, it'll allow them to access services that they may not be able to access otherwise.
So the importance of doing it early when consent will be legal when it's written down. And then also the piece around dissemination of information. So if you have this great plan, but nobody knows about it, not super helpful. Or if you have this great plan and some people know about it, but they're not able to get to it in the midst of a crisis, also not really helpful. So some considerations, but it sounds like there's a lot of choice around that, not only in what is included in the plan, but who is included in the know around the plan.
Exactly. And OHA has helped take the mystery out of some of this. On the form, it gives advice to consumers about, now that it's finished, what should you do with it? And so it advises you to give a copy to your prescriber. It advises you to make sure your representative has a copy. But step 8 of the 8 steps, make sure that you give copies of the completed form to any doctor, provider, or facility from which you expect to need treatment. If you have an appointed representative, make sure that this person also has a copy. Your instructions can't be followed if they are not known to exist. So exactly what you were talking about, Chris, that even if you're super planful and you have this form, if it's not appropriately disseminated, people aren't going to know what your treatment wishes are. And so handing it to all of those people. One of the things that Andrea and I have talked about is how far reaching can these forms be? So say I'm traveling and I'm having a crisis. I'm not going to be able to preemptively give this to every single ER across the state or across the nation. So what can we do if someone is somewhere where they typically aren't and find themselves in crisis? And how can others know that this exists? And one of the kind of simple things, which also is going to have some pitfalls, is having some kind of laminated card on your person that if you come into contact with other people, that people can find amongst your belongings, that simply says, I have a declaration of mental health treatment. My representative is, here's the name and their phone number. And I know people lose their identification, people lose their wallet. So this is not going to be foolproof. But at the same point, anything that we can think of creatively that can allow other people to know that something exists would be super helpful. So if we can get local ERs use Epic as a way to centralize treatment information, perhaps there's a way that we can get the word out and consult with folks to have something on that level. There are a lot of creative, intelligent people in the world, and I have to imagine that getting the right people in the room, we can figure out and problem solve some of these potential pitfalls. And speaking of research, this is one of the things that Andrea and I want to look at as well, is in addition to providing education to providers, but also talking to providers who've been around for a while, who have some experience with psychiatric advanced directives or even DMHTs here in Oregon, and what they've seen the pitfalls be, and how can we help develop a system in which we avoid those potential pitfalls. If we know that this is something that has been a problem, how can we help facilitate the implementation of these and the utilization of them in a way that avoids those pitfalls? And so we certainly don't know how, we certainly don't have all the answers, but we certainly have the passion to figure out what those answers are and to communicate that with other people, what we find out.
And I think it might also be helpful to note that this is like an emergency crisis plan. So yeah, there are going to be some times whenever it's not implemented flawlessly or perfectly, or there may be times whenever it fails, but that doesn't undercut the times that it does help people and that it is incredible. People still die in car accidents when they were wearing their seatbelt, but no one uses that as an argument against wearing seatbelts. So it may not be perfect. There may be times whenever there are holes, but hopefully on average, it's still helping more people and helping connect people to more services that they may not have otherwise. It may not be perfect, but it's also an emergency intervention.
One of the questions earlier was the nuts and bolts of how do we get to use this and how do we envision this implementation happening? If we can educate local providers, therapists, outpatient providers, prescribers, that these exist and that there's some utility in them being completed, that maybe people who are in outpatient treatment, maybe therapists can start having conversations with individuals and at least get the word out that this exists. So should they find themselves in crisis, that there's a plan in place that they've developed. The same with prescribers. So getting it implemented with people who maybe have never had a crisis before and are literally just saying, yes, you have my permission to treat me. My well person agrees to take medication. So then you don't have to worry about forced medications and going through those processes. You have someone's written consent already for psychiatric medication. And then also people who've had a crisis before. What a wonderful opportunity when someone's not in crisis to say, there's this thing that we could try to utilize to try to circumvent difficult things happening or to lessen the impact of a crisis. It's one thing to have a crisis. It's another thing to have a crisis and get arrested. So if we can minimize the impact of this crisis, what a wonderful way to help someone utilize the resources that are available without worsening the situation. Like it's already bad enough. And so someone who's had a crisis, I think early interventionists. So there's resources out there for people who've had a crisis and to help them prevent those crises from happening again. Like what another great tool for that early interventionist to have access to. And then I think of people who may come to the local ER a lot, who maybe doesn't have the resources or doesn't have a primary prescriber and just knows that when something's amiss, that's where they end up at. Once they get stable and have some insight and are determined to have the capacity, conversations could be happening in ERs about having a plan in place to prevent something. There's also longer term psychiatric facilities in the area to where things could be happening at the back door about discharge planning, like I mentioned earlier. All of these different stages are fantastic opportunities to provide education to consumers, regardless of their age or how long they've been ill. If somebody is in a space where they can hear the conversation should be had.
We tend at the center to work so much at the intersection between behavioral health and criminal justice. And so I'm wondering if these are also conversations that could happen when someone's going through a mental health court and are looking at graduation or are releasing from a facility and they're talking to their therapists or release counselors or talking to their probation parole officer when they're doing well. Can criminal justice professionals start having these conversations as well and say, hey, have this conversation with your therapist? Is that something that's possible?
Absolutely. And not only is it possible, but it's recommended. Like anyone can be educating anybody else about these forms existing. So I think you raise a fantastic point. People with SMI find themselves incarcerated very often. And so if someone in the prison system at release can talk about ways in which to prevent further crisis or to have a plan developed in case they would find themselves in crisis. Oftentimes when you have someone who is in some kind of facility, whether it be a state hospital or a prison or a detention center or a jail, there's still people who have eyes on you, who if something starts going awry, they can intervene. When we're in the community, we don't have that level of oversight, which is nice to have that freedom, but it also a disadvantage is not having people able to see what I'm not seeing or understand what I'm not understanding. And so having anyone involved, mental health court would be a fantastic place where an attorney or a judge can say, have you considered a declaration of mental health treatment? Do you know what that is? And to be able to provide education. We think about this toolkit that Andrea and I have developed, having everyone have access to that in an easy way, whether it's different courts, prison facilities, outpatient providers. Like I envision this way where there's an easy link to a website or cards or just something to where it becomes second nature, that everybody's talking about them and everybody has one. People who've been well and never have had a crisis, and people who've had one crisis, and people who've had 50 crises. Like people talk about guardianship and conservatorships pretty regularly these days. How lovely would it also be to have DMHTs in that conversation, to where you don't have to rise to this level for civil commitment? There's help before that, and help that you approve of before that.
Having a plan for before it gets to crisis and having a way to talk about that plan, having that be a conversation that we're talking about all the time in different places. So it just becomes a normative conversation that we're always having. And so folks are used to talking about it. I'm also wondering, as I'm listening to you, it makes me think I'm a runner. And you can get those bracelets, or you can put emergency notifications on your iPhone. It says like, I have asthma, I have all these things. So I'm also wondering if that's a possibility, if you could have identification like a bracelet or a tag, or on your iPhone, you can have your emergency stuff that comes up that people can swipe up and see. I'm wondering, are those also possibilities for helping people know, especially if you're traveling and folks don't know you, that they know that this exists?
I think all of those ideas are fantastic. Andrea and I have also talked about like those medical ID bracelets in some way. What we're really trying to figure out is when those fall off, what is the way that we can let other people know about these in place if I'm not in a place where I can say, hey, I have one of these. And I think the more little tools we have, so say you have a card on you in your wallet, say you have a bracelet on, say you have that information filled out on your phone, like one of them has to work. If we have multiple ways of educating people about the plan that we have, one of them will work.
We're trying to have seatbelts and airbags.
Right.
Exactly. Well, I am a plan A all the way to plan double Z kind of gal myself. So I like the thinking on that, having multiple opportunities. You have it with your local emergency room,
Mm-hmm.
law enforcement, provider, you have cards on your phone. So then at least somebody with the possibility of multiple people, multiple ways of disseminating it, increases the probability that someone's going to know about it and be able to intervene early so your wishes are known. I'm wondering, as we're chatting about this, and I'm thinking about the letting folks know. So I think we alluded to this earlier. When you travel, so you can still let folks know. They may not be able to say the difference between hospital A and hospital B, but they would know what meds work for you versus don't work for you. And if you talk about why hospital A versus hospital B didn't work for you, then that may help even when you're across the country traveling. I could see where that maybe would be helpful as well.
I don't know if an Oregon DMHT is able to be enacted in Wyoming. But what I do know is that if a provider in Wyoming reads your plan and sees that you're allergic to medication A, that provider, even if there's not a lot of legal weight to the document, that provider is still going to appreciate that you experience significant side effects from medication A and avoid it. So even if there's no bearing to the form, or even if there's no legality to the form in another jurisdiction, it's still going to be useful information for someone to know about you.
I'm not sure if DMHTs are enforceable in other states. Right now, about 25 states have statutes that specifically outline provisions for psychiatric advance directives. And even in the states that don't have those, they may be able to use the regular medical advanced directive form to also talk about psychiatric crises. It's going to vary from state to state. To be direct, the form doesn't have a ton of teeth, even in the state that it's initiated in. There are lots of ways for it to be overridden, unfortunately. So even if it's not strongly enforceable in another state, just the pragmatic aspect of it, as Erica was talking about, just to note that this has worked for me, this hasn't worked for me, I have these allergies or these side effects, that is valuable in and of itself, I think.
And because the form is so freestanding, you can explain what your symptoms are when you're in crisis. When I'm in crisis, I become belligerent and I get paranoid that people are out to get me. And I'm likely to think you're trying to hurt me. Because I think that way, saying these types of things to me are known to calm me down. You can get however specific about yourself on this form. And again, even if the form doesn't have a lot of teeth in that way in other jurisdictions, it's still going to be incredibly helpful information for people to know about you, especially ways to not further agitate me. If I know I'm going to get agitated because people ask me questions, like maybe there's a different way you can get information from me without asking me 21 questions while I'm trying to save myself from whatever group of people who I think are after me.
Or even if you've identified a preferred provider in your DMHT, if you're in another state, the provider who's treating you there now has someone to try and reach out to get records from. Because there are occasions where if folks are not able to really provide the comprehensive mental health history, it may be difficult to know where to even start to try and get collateral records. And that could also be a potential benefit.
And when it comes to issues of continuity of care, there are rules in place that allow physicians or providers to speak to each other for continuity of care purposes without needing a release of information signed. And so this would be one of those examples in my mind where I have somebody in crisis and I'm trying to figure out what's the best course of action. If I know that provider's name, I can call that provider and say, I have patient X with me and I understand that's a patient of yours. Things are not well. How can I be of service? What can I do that has been successful?
When I hear you talking about this, the words that keep coming through my brain are voice and choice. And it's really giving the opportunity for voice and choice to be heard. It may not be enforceable, especially in other states. There may be times that it's overridden, but it really gives someone an opportunity to make sure that their voice is heard and their choices are known. Whereas if this form hasn't been filled out and witnessed, then that opportunity for voice and choice wouldn't be there at all. So for me, it sounds like I have an opportunity to say what I want. There may be reasons that they may not be able to be followed to the letter of what I have laid out, but I have that opportunity versus if I did not have this in place, then my providers do not have the opportunity to know what I wanted, what I have laid out works for me or doesn't work for me. It gives me an opportunity to have that voice and how important that is, even though there may be some complexities around if it's followed to the letter or dissemination.
Exactly.
It also gives providers someone to collaborate with who knows the patient, knows their history. It gives them an opportunity to work collaboratively with someone to try and figure out what would that person would want for themselves. And so I think the role that the representative can play is also just so important.
Andrea, you had made the point when we were talking earlier about we didn't learn about these in graduate school.
Erica and I did some research where we surveyed providers, and part of the reason we wanted to do that is because in our experience, no one really knows very much about these. And a good piece of that is because it's not really part of our mainstream education, I think, for the majority of providers. So we didn't learn about this in graduate school. I learned about it because my mentor was a big proponent of these and he talked about them with us. But in terms of classes or practicums, things like that, never learned about them. Erica and I discussed them whenever I was on internship. and it went from there. But it's not on the EPPP, which is the national licensing exam for psychologists. It's not in the state licensing exam for psychologists. It's not commonly discussed. There was a big pop of research about this maybe 15 years ago, and it's been pretty quiet since then. A bunch of these laws got passed in the late 80s, the early 90s, and other than those sort of two pops of interest, historically there hasn't been a lot of conversation, which is really unfortunate because prior research also shows that folks are much more likely to execute a DMHT if their provider supports it. Provider support predicted people completing one of these forms, and then also collaborating and having a session specifically set aside with a provider to complete these forms also predicted completion of them. So having providers on board is a huge boon to having these in place. And so that's why we decided to look at providers. We felt that not that many people knew about them and they could be a crucial piece. Also, we've talked a lot about the impact of DMHTs on individuals who execute them for their own mental health, but I think it's also worth noting that these could have an impact on providers, especially providers who are facing burnout and moral injury, working in systems that are ineffective and where we see people who we came into this field to try and help. Whenever we see them being diverted through the criminal justice system or having these really negative outcomes, especially whenever we see people over and over again, it can be very discouraging in our work and contribute to burnout and moral injury. And so whenever we surveyed providers, one of the first things that we had was an open-ended response box. And we included several of those responses in the manuscript because they were so powerful. People were really sharing a sense of frustration, a sense of futility. Many people were saying things like, there's no hope for this person. There's no hope for this person being diverted out of the criminal justice system. Some people recommended just moving to a different state. There were a lot of responses that really evidenced futility. And I think that providers having confidence that they can bring tools that are going to be effective to create change in the lives of the people that we work with is also a powerful thing.
I think educating people that, especially in a state where civil commitment is difficult, I feel like in Oregon, with my experience, being civilly committed has a very high bar. So when they say imminent danger to self or others, it is imminent. And this is a wonderful option to have someone be treated without needing to meet the civil commitment standard and having permission to treat that person. So there are other options on the table. Getting the word out about what those other options are is imperative, not only for the individual, for all the reasons we've discussed already today, also for the providers that Andrea just mentioned, and that feeling of defeat when what we've tried to do so many times hasn't been helpful. But then another thing that may be worth talking about is the impact on systems. And while I'll speak for Andrea in this moment, while our passion lies with the individual and doing the most we can to improve the life of the individual, the happy accident of helping an individual in that way is the lightening of the load on the systems that are involved. To be really frank, if I work myself out of a job as an evaluator because less people are being referred for competency evaluations, because less people are being arrested who are in crisis, and more people are being appropriately diverted away from the criminal justice system, okay. I'll be okay not working. I'll be okay with that. There are many more things that I am interested in besides being an evaluator that I would have the opportunity to pursue. And I think we talk about trauma. Secondary trauma is essentially what Andrea was alluding to earlier when she was talking about the impact of feeling defeated and having these moral injuries, preventing secondary trauma of all of the people in our system. The amount of money that this would prevent being spended and using those monies for other types of resources and services, outreach, proactive parts of systems that we don't see get a lot of attention because we're so busy being reactive to when things happen. I think a shifting of the way that we think and a shifting of those monetary resources is something that could be a possible consequence of providing folks education about them. And that could be a happy accident to increase implementation and utilization. And maybe that's too much of a positive attitude. Maybe this is me putting too many eggs in this basket. But without trying, without providing the education and getting these in place and seeing if they work, we did some numbers crunching when we were looking at our research and looking at what would be the impact of this fiscally if 10 people had a DMHT and utilized it, and 10 people were diverted from arrest, state hospital admission, and the like. What does that money look like? And I think Andrea has the figure perhaps in front of her.
$1.7 million. If we diverted 10 people from being arrested, sent to the state hospital for competency restoration, using prior research that estimated like an average number of days for competency restoration, and then using numbers that have been published in the newspaper regarding local state psychiatric hospitals, the number would be 1.7 million. And that's if it only worked for 10 people. So these are documents that have the potential to have an exponential impact on consumers, providers, and the systems that we work in.
And it's for all of those reasons that we are so passionate about getting the word out, because I feel like there is such a phenomenal potential of impact, of positive impact on our communities and the people that we serve, most importantly. And for me, that has been what has continued to fuel my passion. I think it may be important to share the story about how I became involved in these conversations. So Andrea was an intern. I'm the training director of our psychology internship program at the hospital, in addition to working for the forensic evaluation service. So we were in supervision, and Andrea was telling me about psychiatric advanced directives. And I really had this in the moment. Wait, what? Like, what? How do I not know about this? Like, I know about medical advanced directives. I've dealt personally with medical advanced directives for parents and grandparents. Like, how did it never come across my brain to think about a psychiatric advanced directive? As a psychologist, I'm embarrassed that I didn't know or didn't even think to like carry this medical advanced directive to my own area of expertise. And so we talked about it in supervision, and she was telling me how they worked. And nationally, the context for this conversation are the things that are happening across the country about, in Oregon, it's referred to the 370 crisis, but the aid and assist or the fitness to proceed crisis, where there are so many orders for these and not enough evaluators to see people or resources to get people seen in a timely manner. So this is something that's happening across the nation. And we're talking about length of stay issues and hospital level of care issues. And so in the context of that zeitgeist, Andrea educating me about these kind of floored me, because in Oregon, we're lucky enough that this is already in statute. Like, Andrea and I aren't even going about this as a way for legislative change. Like, it's already in the law. Like, we just have to fill out the form. And so it's been mind-boggling to me that we have this potential added avenue to really affect positive change. And my personal feeling about it is it's been forgotten. Like, people just forgot about it. And I think in Oregon, it was enacted in 95, 96. And I am sure the people who were involved with that were equally as passionate as Andrea and I, and really felt that this was going to have a really positive impact. And perhaps just over the course of time, as those people retired and their mentors also retired, maybe it was just forgotten. Andrea and I are looking, we talked about those potential pitfalls. Andrea and I are looking into, did something happen to where people thought this is no longer effective or this isn't going to work for reason X? And we just were too earlier in our careers. Granted, I've been a licensed psychologist since 2005. So when I say early career, perhaps that's not the best way to put it, but perhaps these conversations were happening before I was trained and before I was working as a licensed psychologist. So really trying to find out what happened to make these no longer be a part of the conversation. Did it ever get off the ground? Did it get off the ground and then something happened where people were deciding against it? In this packet from OHA, in the acknowledgement section, it talks about the editorial board and the people who were involved in making the form. And the Oregon Advocacy Center is noted, which is Disability Rights Oregon now. So really key players in the community on some level have had their hands in the project of at least creating the form, taking it from statute and taking it to an understandable way where people can fill something out to give to providers. And so that's something we want to look into to figure out like what happened. But the astonishing thing is that people are having conversations about all of these system impacts and the money and being at capacity. This could really help not only the individual, but all of the systems that reach the individual when they're in crisis. And so it's been something that's been really just shocking to me across the way and learning about them, but then also something that's just frankly been really easy for me to get on board with and become an advocate for, almost because of its simplicity.
Erica's experience isn't unusual. Whenever we surveyed providers, we had 225 people participate in the state of Oregon. And out of those 225 people, whenever in the research that we had a vignette that would have been a perfect case for a DMHT, just really a good fit for this exact type of document. And out of those 225 people, only 17 providers identified a DMHT as a possible solution. And then we had a debriefing question at the end of the survey, which asked if anyone had recently spoken to us about DMHTs. And 3 of those 17 said yes. So we had 14 people who identified a DMHT out of 225. But then even sometimes within that identification, they were still saying that it wouldn't be effective. So one person commented, "Oh, I didn't really consider a DMHT because they don't really work." And so there's a lot of misinformation out there about people don't know about them. And then the few folks who do, I think, have a lot of misconceptions about what they are.
I didn't know about them either. So I graduated with my master's degree 15 years ago-ish. I really shouldn't talk about how long ago that was. It's always really rude when I say that to myself. But it was a while ago. Let's be clear, it was a while ago. I didn't hear about these in my graduate program. And we all connected before the pandemic. And I hadn't heard about them. And I was so excited when you were telling me about them because I thought, what an amazing tool that we can just continue to put in the toolkit, right? Because
Right.
this is an incredibly complex problem that we are facing. And there is no easy answer. If there was an easy answer, we all would have solved all the issues that we're looking at. So we need multiple tools. And I was really excited when I heard about it. And when I started asking folks about it, they either hadn't heard about it, or if they had heard about it, there were so many misconceptions around it. So I'm thrilled to have you two on the podcast today to really be able to talk about what it is, how it's helpful, and some of the myths around it. Because I think folks just hear it doesn't work and then it's no longer a tool. So I'm really excited with that. And I'm assuming that this can be found online with OHA.
I just want to differentiate between two things. So there's 127,736 in Oregon Revised Statutes has the actual form of the declaration. So it has all of the pieces of content that you need to validly execute a DMHT. That is available to anyone who wants to Google that statute and then literally copy and paste it and fill it out. There is a different form that was put out collaboratively by OHA and at the time Oregon Advocacy Center and some other agencies that includes a lot of really helpful information, including like FAQs and steps on how to implement it. And that form is a little bit harder to find, but we have it, the most recent version.
I'm wondering, would you be willing to send the links to me, and then we can put them in the episode notes.
Mhm.
So
That would be
then
awesome.
folks can just click right for our listeners when you're listening to this podcast. If you go wherever you get your podcasts, whether it's our website or wherever you get your podcasts or YouTube, you can go in and click on the episode notes. And then we always have what the episode is about. And then we also have helpful links. So we'll be sure to have those links when we release this episode so that you're able to access these forms and the statute.
And I think it's helpful to note that the statute, just like Andrea was saying, the statute is the easiest place to go to find out all of the mechanics of what is involved with the declaration of mental health treatment. It is going to be a little dense because it is law and trying to wrap your mind around all of those things. But the statute is the easiest place to go to find out literally everything there is to know about them as it's delineated in the law. And then the link to the form will really help an individual who's interested digest the information that's delineated by the statute. So the frequently asked questions, the components of the form, what the form can do and what it can't do is very specifically talked about in the form that OHA put out. And so those are the two sources that are really going to be the most helpful.
Yeah. And that statute has the form. It has the statutes and everything, but then it has the actual form that you could just print out and have your witnesses sign it and you fill it out. And so it's there. But the more comprehensive form that has the FAQs is very helpful.
So that's the big difference. So the statute has the form that you can print and sign. OHA has taken that form, kind of beautified it a bit, made it more user-friendly, and included frequently asked questions. And so if you don't ever look at OHA's form, you're still going to get information and what you need to fill out in the statute. OHA's form just makes it easier to read and to understand.
Absolutely.
Statutory language can be a little dense sometimes and hard to digest and understand. So it sounds like OHA's form took that and then made it much more user-friendly to fill out the form. And with the FAQs, then I'm sure lots of questions come up. So then you have that right there. So you don't, if you're just looking at the statute without looking at OHA's, you may be asking yourself questions that are answered if you went to look at OHA's form. So we'll put in both so folks can go and look at either.
Perfect.
And we encourage you to go and look at the form and have conversations about the form and start using this tool in Oregon. In the time that we have left, I'm wondering if you have any last thoughts for our listeners.
I want to give just a brief synopsis of the research that we did, just because I think it'll help people understand it. We wanted to survey providers because we felt that they were important in helping DMHTs get implemented. We also know from prior research that 70 to 80% of consumers say that they want a form like this and that there are laws in place, just as we've discussed, that can help make that happen. But we were trying to figure out what the disconnect was between consumer desire and there are laws in place that support it, but for some reason no one knows about these and they aren't being implemented. And so we started by surveying providers, and we had 225 providers respond to our survey, which was incredible. About half of those were folks from the state hospital, but we also used other professional listservs in the state to get access to other respondents. Our major finding is that people don't really know about these. So we were able to empirically confirm our anecdotal impressions that people just don't know about these and that there was a ton of misconceptions about them. We gave a vignette that involved a young man who had recently had a first episode of psychosis. And we outlined circumstances where he had been stabilized and was now trying to plan ahead for the future. And in the vignette, his mother is available as someone who is invested in his care and wants to help him in the future to manage such psychiatric crises. And we found overwhelmingly that people didn't identify DMHTs as a potential option. People tended to not know about them, and folks tended to have very low confidence in their ability to help that family navigate their desire to plan for a future psychiatric crisis. People who knew about DMHTs had more confidence in their ability to respond, but they still weren't showing super high levels of confidence. So then we provided a brief education about DMHTs, and we asked true-false questions about the statutes in Oregon prior to providing education, and then we asked true-false questions again after. And it was just a very short intervention. All total, the survey only took 15 to 20 minutes for people to get through. So we're talking about very brief education. But in the second set of true-false questions, if people got one wrong, they were given corrective feedback and the statute. So we knew that people were actually learning as opposed to just clicking through a page with bullet points on it with information about the statutes. So after that second set of true-false questions, whenever we asked people to consider the vignette a second time, their confidence and their feelings of effectiveness in being able to help the family rose significantly. So there was a significant improvement in their feelings of confidence and ability to help the family face the challenges that they were facing. However, even with that significant rise, people were still in this sort of moderate range of confidence and feelings of effectiveness in being able to help the family. So we're interpreting these results as once people learned about psychiatric advance directives and learned about the laws in Oregon, they felt better about their options, but that people are still seeing some barriers to being able to implement these effectively. And that can be all of the things that we were talking about today in terms of people's ability to implement these. So we're hoping that this means that with additional support, maybe additional toolkits, additional trainings, more understanding of DMHTs, people would be better able to implement these effectively. And one other thing that's noteworthy is our very brief educational intervention only covered the facts of the laws in this state. It didn't cover any of the other research that we briefly touched on, including things like coercive outcomes are reduced, people are more engaged in treatment, feelings of autonomy and self-determination and empowerment are increased, that consumers find them valuable. All of these other aspects of the pragmatic outcomes of DMHTs weren't even touched on. And so hopefully if providers had even more information along those lines, that would increase their willingness to use these tools even more.
And I think that leads to some other bullet points that we talked about, but maybe not as directly. So essentially with the research that we've done, this has made us more interested in gathering additional research about pitfalls and barriers, but also to be involved with future research and future implementation. So how can we best help the community learn about these and implement them successfully so that they can be utilized successfully? So one of our big goals is just to increase awareness and increase accessibility to these forms. And what's really nice is that this podcast is a really easy way to do that. One of the other things that we wanted to touch on as far as system impacts that we've mentioned, but I think we owe a service to mention even further, and that's the families that are involved. I'm going to get emotional. I have done so good this whole time. Okay. So I think one of the things that's important to note are the families that are involved. And we hear stories after stories from consumers and families about how difficult it is to know what to do in a time of crisis. And having tried to help so many times, and that help seems futile. And so for their own sense of survival, they've just stopped trying to help. And they've said, I can't keep doing this to myself. And so I'm not going to put myself in that situation, and kind of move on to healthier ways that they feel like they can be involved. And so one of the things that I think is really helpful about this is that if we can get the word out and that these can be implemented, we could potentially be helping families not reach that period of burnout and being able to remain involved in the consumer's life despite crises happening. You hear stories, whether it be in the news, the newspaper, different podcasts you may listen to, where you hear about people burning bridges with their family or community resources because they've been difficult to manage, and it being difficult for families to be involved on that level of involvement. And so if these forms can be implemented successfully, we may really be giving opportunities for families to be saved.
Being able to keep families whole. We all have heard those stories over and over again and have seen those stories play out. And what an amazing tool that these psychiatric advance directives could provide in helping keep families together, and the possibility that these directives may be a helpful tool in that, I think, is a really wonderful, hopeful place to end the podcast today. I thank you both so much for joining me. I am excited to be able to spread the word about these directives in Oregon. I think they're yet another incredible tool that we can have in our tool belt, and I'm excited to link to them in our episode notes so folks can go and take a look and start having conversations about them. I really appreciate your time today. I appreciate how much compassion and enthusiasm you have around these directives, taking the time to help talk about how they work and the myths around them and how they may be helpful. So thank you so much, both Erica and Andrea, for joining us today.
Thank you for having us and for giving us a platform to talk about these tools, which will hopefully be helpful.
Yes, thank you so much.
The Center Collaborative is a production of the Oregon Center on Behavioral Health and Justice Integration, a specialized division of Greater Oregon Behavioral Health Incorporated. It is produced by me, Chris Thomas, with production assistance from Patrick Kennedy. Music by Patrick Mulvihill and Patrick Kennedy. Subscribe to the Center Perspective using your favorite app. To learn more about criminal justice and behavioral health in Oregon, visit the Center's website at ocbhji.org. You can also find us on Facebook. We'd love to hear from you. Please reach out to us. Join us next time as we chat with the experts about programs and partnerships at work within this complex and yet compelling field.